Hello friends, welcome to Insider Ophthalmology Simplified. In today's class we are going to discuss about management of dry eye disease in the form of medical, surgical as well as general measures to treat dry eye. Coming to the general measures, we have to avoid the exacerbating factors. So what are these exacerbating factors? So high temperatures, wind, humidity, and other drugs which we consume on day-to-day basis. We have to perform some sort of workplace modifications so that there is reduced development of dry eye, such as performing fast blinking exercises and taking rest following the 20-20-20 rule. And also we need to maintain lid hygiene with the help of warm compresses, topical antibiotics and systemic antibiotics when necessary if there are any infections, and also artificial tears, and also we'll discuss that in the medical management. And we also have environmental strategies. So depending upon the drugs which we take, we have to avoid some of the medications, and also some ocular medications which contain preservatives should also be avoided. We have to reduce the stress and follow 20-20-20 rule. That is, we need to take for every 20 minutes a 20-second break and look at a distant object which is 20 feet distance. Right, coming to the medical management, we have it is a dryness of eyes, right? So either we have to substitute the tears, or retention we have to increase, or stimulate the secretion of tears. Okay, so artificial tears are the tear substitutes. So the examples of these include carboxymethylcellulose, hydroxypropylmethylcellulose, which are plant derivatives, polyvinyl alcohol, propylene glycol in the form of gels, ointments or drops, hyaluronic acid and all. So these are all the artificial tears. Then retention can be done with the help of occlusion of the outflow. So we use contact lens for that. And stimulation of tears, we have newer drugs like diclofosol, rebamipide and giternate, ecabet sodium. So these three are mucus secretion stimulation, whereas diclofosol is a P2I2 receptor agonist. Then we have some treatments like anti-inflammatory treatment. For this we can use topical cyclosporin, corticosteroids, oral tetracyclines. So these are required in some of the other etiologies, not the common ones. So where inflammation is the cause. So we have Steven Johnson's OCP and all, right? So in those cases we require this type of treatment also. So this topical cyclosporin has been approved by the FDA. So it reduces the interleukin 6 and it can be used, whereas these tetracyclines reduce the matrix metalloproteases and reduce the interleukin 1 secretions. Now we also have the medical management with the help of essential fatty acids. So this there has been studies that this mebumin lipid composition has been altered, so which leads to dry eyes and all. So that's why we have to give essential fatty acids in the form of oral cod liver oils and all. So these reduce inflammation. Okay, so this was regarding the medical management. Now coming to surgical management, we have the same principle, that is tear substitute, tear retention, and tear stimulations, right? So how do we perform this surgically? So in the occlusion of upper lacrimal pathways, we have the canalicular excisions, punctal plugs, okay, and in lid procedures we have tarsorrhaphy, blepharotosis, and amniotic membrane grafts. In lacrimal substitutes, we have salivary gland transplantation, which can be either major salivary gland or minor salivary gland transplantation. And we also have this parotid duct transplantation and dacryo reservoirs. So these are the reservoirs which are placed somewhere else, commonly in the abdomen, and from there these reservoirs pump the lacrimal fluid into the eyes. Then we have lubricating inserts and valved aqueous tube shunts also. In tear stimulation, we have true tears. These are the recent advances. Then we also have tear implants and corneal neurotization. So this was regarding the surgical management. And just a note on punctal occlusion, it can be either temporary or permanent, and we can use collagen plugs for temporary, whereas permanent it can be with the help of either silicone plugs, punctal cautery, diathermy, or laser coagulation of the punctum. We can also divide it in the form of absorbable or non-absorbable. So in the absorbable one, we can use catgut, gelatin, HPC, and collagen. So these are used when the occlusion is required just for weeks, whereas non-absorbable ones include silicone, Teflon, hydroxyethyl methacrylate, and polyethylene, PMMA. These are all non-absorbable ones. So they have their effect for a longer period. Okay, so this was regarding the surgical management. I hope you like this video. Please subscribe for the latest updates. Thank you.